All right, kicking us off this morning are two first speakers, Dr. Helen Merritt and Dr. Karen Trujillo. They are both cardiothoracic surgeons at Methodist Hospital and Methodist Physicians Clinic. They will be presenting on new frontiers in cardiothoracic surgery.
Thank you, Carrie, and thanks everyone for being here. Apologize for the kind of casual, but I have a new frontier in cardiac surgery immediately after this that we're addressing. So we're going to talk about what's old, what's new, and what do we do for some challenges that we face in cardiothoracic surgery. An update as to who our team is. So in 2020, I joined Dr. Batter, who's in the middle. You guys probably all know / love him. And then Dr. Trujillo joined after that. And then Dr. Rosenkrantz and Dr. Langdon about the same time. So there's now 5 of us, where there was one person doing all of the things at Methodist Hospital, both cardiac and thoracic. That's allowed us some excellent teamwork and support of one another as we innovate and try new technologies that we can apply to some complex issues. We also have 4 inpatient nurse practitioners, 2 nurse coordinators, and 1 clinic nurse practitioner, 2 schedulers in our clinic, the LCC support staff, 1 structural heart coordinator and a structural heart nurse practitioner, and 5 cardiac ORPAs, which we couldn't do any of the things we do without this excellent team supporting us. So I do want to acknowledge that. Here are some great quotes about cardiothoracic surgery. So in 1880, Bill Ross said, "Any surgeon who wishes to preserve the respect of his colleagues would never attempt to suture the heart." Luckily, we don't care about the respect of our colleagues, so we did go ahead and do that. And we've come a long way since that quote. For thoracic surgery, it requires a courageous decision of optimism to suggest that the time will come when a complete resection of early carcinoma of the lung with a careful dissection of the regional lymph nodes can be carried out with a fair prospect of success. Hopefully we've passed that as well. A little bit of the history of cardiothoracic surgery. So thoracic surgery actually got its name by helping treat tuberculosis, which was at first really a surgical disease where there was no cure whatsoever. The treatment would consist of removing part of the lung and removing part of the infection, as well as taking out some ribs and deforming the patient, bringing them down so that they had what's called a thoracoplasty, and taking care of the space, because we know when there's space, the body fills it with fluid or infection. The other thing that we would do is a plombage, which you can see in this picture over here, which could be done with a bunch of different things, where we'd fill that space with things like, saline implants or ping pong balls or whatever people would think of to fill the space. In 1880, Bill Roth did make the comment about suturing a cardiac wound, but it was done successfully about that same time. In 1910, Dr. Carell attempted a bypass on dogs, which was not super successful. In 1920, a urologist named Forsman actually used his own arm and a catheter to go under X-ray up to the heart. So that's where we get the term cardiac catheterization. So kind of interesting, gives a little street cred to urologists. And in the 1940s, congenital cases took off, except we didn't have a heart and lung machine like we have now. We didn't have an oxygenator. We didn't have the ability to screen for bubbles or for clots. And so we actually used the patient's parents to do that. So it relied on a good pump and a cross match. And then the patient's mom or dad would be cannulated in the groin and supply the whole blood supply and the cardiac function to the child while they were having surgery. Dr. Weinberg then took an artery, and instead of attaching it directly to another artery on the heart, just put it in the muscle, and that seemed to work okay. In the 1940s, lung cancer surgery really took off, but in the 1960s, we got ripe therapy for TB. And everybody was like, oh no, now cardiac surgery and thoracic surgery is going to go away. There's no role for it. They're going to become obsolete. And you'll see that this is kind of a recurring theme. So I put EEK because people are like, oh my gosh, we're going to have to get a job at McDonald's. I don't know if there was McDonald's then, but and then the first PCI came out, and it was balloon PCI, and it worked pretty well for a couple, 3 months or so. And so that again was where, cardiac surgeons were thought to be obsolete, because we're not going to be doing bypasses anymore. We're going to be doing PCI, and nobody's going to have their chest cracked open anymore. So we started innovating. We looked at mid-cab, which is where we do a minimally invasive cabbage through the right or the left chest. In the 1990s, we started looking at heart failure. And if there was any way that there's a role for surgeons in heart failure, which was thought to be kind of crazy at the time, but the VADs came out. It's kind of like the first computers where you're walking around with like a card about this big, like the total artificial hearts are now. And then in the 2000s, off-pump CABG started to be pioneered and robotics started to be pioneered. You can see in the pictures over here that the VADs now are much, much smaller. They go in through oftentimes an apical incision, just a left mini thoracotomy rather than a sternotomy itself. I do want to give a couple shout outs to, with it being National Women Physicians Day 2 days ago, to Dr. Helen Thoracic, who helped pioneer the Blue Babies operation, the Blaylock Thoracic shunt for patients who had no options at that point in time. And Dr. Nina Starr-Bronwell, who came out with the very first prosthetic valves in the 1960s. So what about our future? How do we continue to innovate? Well, for that, I bring us to an analogy. What is the difference between a river and a lake? Both are bodies of water. A river is a natural stream of water of fairly large size flowing in a definite course, whereas a lake is an expanse of water that's static and entirely surrounded by land. So in cardiothoracic surgery and in medicine in general, we really have a choice of which one that we want to embrace. This is Lake Pupo, which is the second largest lake in Bulgaria. It's 56 miles wide and 26 miles long. And without any changes or innovations, it dried up. Whereas you look at the Mississippi River, which has been named on the endangered river list up to 9 times since 1991. And it's got this, this process where the river meets the ocean, the erosion brings in the silt accumulates and kind of stops the river, but then the river overflows and a new river is created. And I would suggest that cardiothoracic surgery is like that. So, you know, what makes rivers different than lakes? It's movement, it's adaptation, it's having a destination in mind. Same thing for cardiac surgery. It's drive, it's dynamics, and it's intent. So a drive or a dynamic is an innate urge to satisfy a goal or a need. The contrary to that is that we say it's all been done before. You know, we have to think inside a box. We have very few things that we can continue to innovate in cardiothoracic surgery, and there's just too many obstacles to getting that done. And all of those things have been said, you know, for robotic heart surgery, for off-pump surgery, for AFib surgery, for aortic surgery, but we've still got to keep thinking of those things and continuing to innovate. And I would argue that confines actually increase creativity. Anybody who's worked in the OR with me will hear me say that efficiency is born out of necessity. So when you need to, you know, kick it into high gear and do something that you really have very few abilities to make a mistake or to go back on, that's when you focus and you continue to move forward. It's the same thing in cardiothoracic surgery. The Mars rover is a really good example of that. Here were some obstacles that the NASA astronauts were facing as they tried to land this rover on a planet 50 million miles away, which isn't really that far actually. And they're trying to land it into this, this crater that's 96 miles wide and 3.4 miles long or high. And there's just like a small temperature range, just like a day in Nebraska. It's a negative 197 to 104. So that's a huge range, and they're trying to navigate all of this. And they have these 3 different satellites that are in orbit. It says a 7-minute delay. It's really actually a 14-minute delay. So by the time something is happening, when we're hearing about it, it's already 14 minutes later. So I'm going to see if this video will play.
When people look at it, it looks crazy. That's a very natural thing. Sometimes when we look at it, it looks crazy. It is the result of reasoned engineering thought, but it still looks crazy. From the top of the atmosphere down to the surface, it takes us 7 minutes. It takes 14 minutes or so for the signal from the spacecraft to make it to Earth. That's how far Mars is away from us. So when we first get word that we've touched the top of the atmosphere, the vehicle has been alive or dead on the surface for at least 7 minutes.
Entry, descent, and landing, also known as EDL, is referred to as the 7 minutes of terror, because we've got literally 7 minutes to get from the top of the atmosphere to the surface of Mars, going from 13,000 miles an hour to 0 in perfect sequence, perfect choreography, perfect timing, and the computer has to do it all by itself with no help from the ground. If any one thing doesn't work just right, it's game over.
We slam into the atmosphere and develop so much aerodynamic drag. Our heat shield, it heats up and it glows like the surface of the sun. 1600 degrees.
During entry, the vehicle is not only slowing down violently through the atmosphere, but also we are guiding it like an airplane to be able to land in a very narrow constrained space. This is one of the biggest challenges that we're facing, and one that we had never attempted on Mars.
Mars is actually really hard to slow down because it has just enough atmosphere that you have to deal with it. Otherwise, it will destroy your spacecraft. On the other hand, it doesn't have enough atmosphere to finish the job. We're still going about 1,000 miles an hour. So at that point, we use a parachute.
The parachute is the largest and strongest supersonic parachute that we've ever built to date. It has to be able to withstand 65,000 pounds of force, even though the parachute itself only weighs about 100 pounds.
When it opens up that fast, it's a neck-snapping 9 Gs.
At that point, we have to get that heat shield off. It's like a big lens cap blocking our view of the ground to the radar. The radar has to take just the right altitude and velocity measurements at just the right time, or the rest of the landing sequence won't work.
This big, huge parachute that we've got, it'll only slow us down to about 200 miles an hour. And that's not slow enough to land. So we have no choice, but we've got to cut it off and then come down in rockets. Once we turn those rocket motors on, if we don't do something, we're just going to smack right back into the parachute. So the first thing we do is make this really radical divert maneuver. We fly off to the side.
Diverting away from the parachute, killing our horizontal velocity and our vertical velocity, getting the rover moving straight up and down so it can look at the surface with its radar and see where we're going to land. And we head straight down to the bottom of a crater, right beside a 6-kilometer high mountain.
We can't get those rocket engines too close to the ground, because if we were to descend propulsively with our engines all the way to the ground, we would essentially create this massive dust cloud. That dust cloud could then go and land on the rover. It could damage mechanisms and it could damage instruments. So the way we solve that problem is by using the sky.
So long story long, they ended up landing and it was successful. But you can see that there's a bunch of challenges, and that at any point in time, you could say it's easier for us to just be a lake, right? That to not change, to stay within the confines of what we know, but also appreciating that that lake is shrinking over time. So I would suggest that in cardiothoracic surgery and in medicine in general, we have to continue to innovate and to appreciate what's the changing landscape and to be willing to take some of those risks. Also, I wanted to be an astronaut, so I thought that was cool. So looking at our program growth, I do think that it's reflective of what we've been able to do as a team. In 2020, we had one of the few programs in the nation that was able to grow as compared to all other programs. 85% of programs actually had a decrease in their case volumes. Just 15% stayed static or had a growth. And so that's pretty impressive. We've continued to grow and almost doubled our numbers in 2023. We had a little dip because we did less TAVRs essentially in 2024. And you can see that that is reflected here as we do things like convergent, like TAVR, and then our open heart cases have, of course, grown with that as well. I want to shift to talking about some of the things that we focus on. The first is going to be aortic work. The new 2022 ACC guidelines came out, and they had a couple really important things that I've starred here. Number one is that cases should be discussed at a multidisciplinary aortic team. We do have an excellent team of physicians who meet once a month to talk about all of these cases, including radiology, vascular surgery, cardiac surgery, as well as genetic testing, which is available for our patients. At centers with multidisciplinary aortic teams and experienced surgeons, the threshold for surgical intervention for ascendings went from 5.5 centimeters down to 5 centimeters. We do have an aortic surveillance program where we monitor all patients who have an aorta that's greater than 4 centimeters. It also states that in patients who are big or small, that we do aortic size indexing, that makes sense. If you're 7 feet tall, you get to have a bigger shoe size than somebody who's 5 feet tall. So we do that as well. And then they talked about type A dissection and that you really need to do an open distal anastomosis with circulatory arrest rather than just an interposition graft for longevity of patients. So when they talk about aortic centers, they're talking about volumes as well. They describe a high volume center as having more than 30 to 40 aortic procedures annually. Now, I did look at our numbers. So in 2020, we did 14 aortic cases. In 2024, we're up to 57, which is a lot. So that absolutely qualifies as a high volume center. And remember that they're talking about aortic cases of the belly, the descending aorta, they're talking about open, they're talking about TEVAR, and literally all I included here were our open aortic cases for cardiac. So we're well above that threshold for a high volume center. So we certainly meet criteria for that. And actually, I believe, don't quote me on this, but we are doing more aortic work than the med center. Here's an example of a ascending aorta that catches the eye right here. It's kind of big. Yeah, so that was a case we did. This is actually not even the same case, but as we look from the head of the bed, anyone who's been in there, Aaron and Ari in particular, will know that this aorta is like the size of a basketball and shouldn't be there. This was a 7.8 ascending that was found on a shoulder surgery pre-op x-ray. What the heck? Yeah, that patient got care flighted down here. And then we're also doing valve preservation. So there's something called an aortic ring now that we use for aortic insufficiency, that we can preserve the patient's own native aortic valve, similar to how we preserve the patient's mitral valve, which has sort of become standard of care for that. So some cool stuff we're doing. Here's some other specific recommendations. And they basically say that genetic testing can change when we intervene on a patient. So whereas most patients, we would wait till they got 5.5, that's way too big in certain scenarios. There are certain scenarios that we go all the way down to 4 centimeters to replace the root. And it does talk about that when you address these patients, it's not only the ascending, but also the root tissue you need to think of. That becomes more and more clear to us as we provide more and more complex redo operations. I liken this to having a need for ACHD, right? Adult congenital heart disease as a subspecialty. Why do we need that? Well, it's because patients with heart disease that they had as babies, they're living longer. That's great news. It's the same thing for this aortic work, but there's a certain subset of patients that we're going to see over and over because they have these aortopathies. And the great news is these patients used to just die. It was about a 65% chance of not making it through the first operation. But now we're faced with some complex challenges, just like the case we have to do later today, that allow us to need to continue to innovate to get these patients through. So do we stent the ascending aorta? Well, not really. There are some trials. We're involved with one of the trials, but they're only for high-risk patients. The issues are that there's tortuosity in the ascending. So if you look at the descending aorta, it's a nice straight shot. But the ascending aorta has these little guys that are like our brain blood vessels that we probably shouldn't cover. And so that creates a bit of a challenge. Now we do things called deep branching, which is where we bring these arteries down onto the ascending aorta, which allows us to deploy a TEVAR across that. And so we're looking at landing zone here. The arch, we often will provide a hybrid approach for. The real problem is down here in the root and the ascending, which is where most dissections occur. And we don't have anything that's great for that. There's been some studies that is a patient that has had prior post-op interventions. It's not my patient, for the record, for those of you who are judging, but 7 post-op interventions, and then had hemorrhagic shock and bleeding coming out of the sternum. That patient really was not a candidate for a haircut. And so they took him and did an EVAR into the ascending aorta, and that patient lived. It's not first line. This is a study out of Cleveland Clinic where they do about 600 cases per year, which is like a lot, that they treated with a stent placed transfemorally. They had 86% survival at 30 days and 73% at 5 years. Now the kicker is 1 patient died on the table, 2 patients required a conversion in the OR, and 4 patients had a later open conversion. But there's a subset of patients that would have been deceased because they weren't a candidate for anything. And so if you do the math, about 65 of that 72 lived. So you look at TAVRs, right? And, our program started in 2019, I think, at Methodist, and it grew pretty substantially when we were partnered with Pioneer Heart. But you also look at what do you guys think is the fastest growing case for a cardiac surgeon? Does anybody know? Does anyone want to take a stab? That's right. It's explant of a TAVR valve. Okay, so that's the same thing with ACHD, but we have to learn how to do that. We've done, I think, 3 in the past 3 or 4 months. And before that, none of us had any experience with it. So we're still learning about which patients to put them in. The guidelines are a little behind on that because they say may be considered for low risk individuals. Well, do you think there's never going to be a procedure for a 40-year-old who gets a TAVR replaced? No. So it's got to be heart team discussion and then discussion with the shared decision making with the team. So here are some TAVRs as they come out. And the important thing about a TAVR is not just we're going to go pull it out. You can see that there's tissue ingrowth and that a lot of times we end up having to do a root replacement on that patient. And mortality for a TAVR re-op is twice what it is for a SAVR off the bat. So just important to know as we talk about those decisions with families. I also want to touch on our PERT team. This is kind of a stair-step diagram of how we escalate care for patients who present to the emergency room with a PE, heparin, TPA, catheter lysis, catheter aspiration, which are sort of the same, and then ECMO and right ventricular strategies. And then lastly, as a bailout, we have surgery for certain individuals. And these are the different options that we have at Methodist. We've got Penumbra, we've got ECOS, we've got AngioVac. We've also got the RV Impella, which is kind of not really indicated when you have a PE because you're blasting, the flow right across a PE. So, but then we've got epoprostenol, we've got ECMO. This is a super easy graph, right? But I do want to do a couple stars here. So patients who come in with a catastrophic PE, which means they're on high dose vasopressors, they have rapid escalation of the vasopressors, or they have a cardiac arrest or what we call impending cardiac arrest. They need to be considered for ECMO, right? They need to be considered right off the bat for ECMO. Our team needs to be involved sooner than later. Why is that? Well, because they die without it. That's why. And that results for PE for ECMO are actually really good. Now, we do have some barriers in that if we place someone on ECMO, we don't manage ECMO at Methodist Hospital. We send them to the ECMO Center where they do 130 ECMO a year. We do about 6 ECMO a year. And we do sometimes need to sit on those patients a little bit. We do that successfully, but I wouldn't say it's like a streamlined process just yet. Here's a case we did where somebody came in with a clot in transit. She was 84 years old. She had a right-sided PE and a pacemaker that was placed 3 years ago. We actually sucked all of this out, which was pretty cool, and sent the material to pathology, and it was metastatic squamous cell carcinoma. So that changed what we did in that patient. That was with an angiovac. Here's another case where there was a big PE. Doesn't take an astronaut to see it. And we took this patient, we talked about angiovac, we talked about open surgery because they were young with a big clot burden. And ultimately we took them for open surgery. They required VV ECMO post-operatively, but had a full recovery. We do alternative incisions, which help patients recover a little bit faster and provide an alternative for sternotomy in patients who may not be good candidates for a sternotomy. This picture is gross but cool. This was a patient who had a pacer lead that you can see and had endocarditis. The goober, if you will, was too big to pull out with a laser lead extraction. And so we did a right mini thoracotomy, opened the right atrium, pulled out the lead, and this thing was actually dripping pus. It was disgusting, you guys. I've never seen that inside the heart. So I think it's cool. But you can see the incision's pretty small because that's my actual hand, and that's the size of the incision. Here's another patient that had a mini thoracotomy for a aortic valve replacement. The head is up here. The rest of the body is down here. This is an incision through a right second intercostal space. And then here's a mini sternotomy that we did for aortic valve. Again, that's my finger, pretty small. So small incision that the patient received for that. And as you guys are probably aware, we do robotic cardiac surgery. Here's us suturing the mitral valve. This is anterior leaflet here. This is posterior leaflet. We've resected part of the posterior leaflet and are now suturing that back up. And then we place a ring. So some pretty cool stuff. I just came back from STS. I want to talk about multi-arterial versus single arterial grafting for CABG because that may be some things that you guys are seeing. It's harder to do. It's technically much harder to do. There are certain patients who are good candidates for it and certain patients who are not. But the new ACC guidelines came out a couple years ago and recommended that in preference to a saphenous vein conduit to the second most important significantly stenosed non-LAD vessel to improve long-term cardiac outcomes, a radial artery is recommended, and it was a level 1B recommendation. This created a bunch of controversy in our society and with the ACC, because we felt like it was much too strong of a recommendation and that there needed to be some guidelines about which patients got that. Leaves us a little bit open to legal and medical legal criticism if we don't use a radial artery to the second conduit. And so there are certain times that we may not. We are a low volume center for multi-arterial grafting. We don't do very many. It's probably 1 in 15, 1 in 20. I think we can do better with that, myself included. We're part of the Roma study, which is looking at second arterial grafts for women, in particular the primary Roma study came out a couple years ago, and we're going to follow long-term outcomes for that. Again, it makes a difference whether you're a high volume or low volume center for second use of arterial grafts. You can see that as we look at mortality for expected to observed, you want that to be as close to 1-to-1 as it can be. And for low volume centers, it was 1.09, which means there was more observed mortality than there should have been. And you can see that for low volume centers, or for high volume centers, all the way down to 0.86. So it does matter. Same thing with the aortic work. So AFib updates. This is a mug that my team got me that I love. I think it's the cutest ever. No fibbing. These are tiny, so I'll just go through it. There were some recommendations that came out from ACC, and this is STS updates that moved AFib surgery for as concomitant for any patient undergoing heart surgery. So if you have AFib and you're having heart surgery, you should go ahead and have your AFib treated at the same time. CT surgeons are notoriously bad about that, despite having guidelines. In fact, for CABG, only 22% of patients who had AFib got their AFib treated at the time of open heart surgery, which is crazy. You already have your chest open. Why are we not doing ablations? We find reasons to not do it, just like we find reasons to not do multi-arterial. You know, we don't want to complicate the procedure. We don't want to go on pump, whatever it is. Those are the reasons that we use. But really, the guidelines and the data suggest that we should be doing it for every patient, that we suggest clipping the appendage. And that standalone AFib, this was a big one. Standalone AFib increased its recommendation from level 2B to 2A. And that patients who have symptomatic valve disease and AFib who are low or intermediate risk, that should be a tipping point for us for TAVR too, which is crazy. Anyone that's sit in our TAVR conference knows that we've kind of brushed over AFib like as if you have GERD or hypertension, but really it should be a tipping point that's just as strong as a recommendation as coronary artery disease. It should push you into an open category. So that's something that we as heart surgeons and as cardiologists need to really digest a little bit. Our Arrhythmia Center, as you know, I've came to Methodist after proctoring Batter for the convergent procedure. And so it's a procedure near and dear to my heart, no pun intended, but it's an epicardial and endocardial approach to atrial arrhythmias. We are a training center for that. I go out and proctor other programs that are starting it. We're in the top 5 programs in the country for, I think, 2 of the last 5 years, which is pretty crazy in Omaha, Nebraska for how many AFib patients that we're treating. We're also part of the Converge trial, the post-approval trial, and we're part of the LEAPS trial. So we're involved in studies for that as well. Obviously, we have a booming Watchman program, which has been very successful. And we're going to learn this leadless pacer that goes in behind the sternum and is kind of fancy. We sing in the OR, we don't talk about ECMO. This is the song that we have, but we do talk about ECMO. We look at overall survival rates for ECMO have gone up. There's the ELSO registry that follows every patient that's placed on ECMO that participates in the registry. We don't, because we don't do as much ECMO as say the Med Center. But you can see that ECMO has really increased over the years from the 1990s all the way up to the 2000s and 2020s with now a boatload of centers across the United States. It really has become analogous to having a ventilator program, right? That you're at some point probably going to need to be able to support VV ECMO. We are not there yet. Outcomes are increasing from 30 to 58%, depending on the outcomes. Now, I got our numbers after I did this slide, but we are now at 33 ECMO since 2020. We did 6 in 2023 and 6 in 2024. Our survival has been great, which means that we have good judgment for who we put on ECMO. Post-cardiotomy ECMO, which means after you've had open heart surgery and you're in cardiogenic shock, survival for that has been notoriously low across the board, but our survival has been pretty good. It's been about 45%, whereas reported outcomes are about 25%. So again, I think it suggests, number one, we're putting the right people on, and number two, after we transfer them, they're doing a great job managing those patients. So we appreciate that partnership that we have with UNMC. Changes that we've made, our CALS protocol for talking about open chest procedures, who gets an open chest, how do we manage these patients after they come up to the floor if they have a cardiac arrest. We don't do CPR. We stack the shocks, and then we consider opening the chest back up for patients who are candidates for that, and they may have a surgically correctable problem. We also consider ECMO at about 10 minutes into codes at the hospital. That's still kind of becoming more mainstream, but I certainly get more calls asking about ECMO, which I think is great. Oh, that guy is a guy who had CPR for like 2 hours in the OR, and we were able to get him through. I had no idea he was that tall till he came to clinic. I was like, oh my God, seriously? But yeah, so he survived, but he required a bunch of rib plating because we did some good CPR, y'all. Really good. That's great. He had no neurologic deficit. Here's some other monitoring tools that we're using nowadays. We've got a Swan GANS, which we've used and intermittently used for certain populations. CVP is great, but it's not the whole picture. We have some things like the Acumen, which is a great tool that estimates cardiac output, cardiac index, stroke volume variability. The only thing that it doesn't give us is a mixed venous, which is helpful for some patients, and PA pressures, which is helpful in some patients. They have a new one of these that actually doesn't require an art line and can go on like a pulse ox, which is pretty cool. And we kind of want that too, because there's sometimes patients that are tooting along, but maybe they're not quite ready for an art line, or there's nobody in house to do it. If we can just put that on, it can give us some information about it. I think it's been really helpful. Our nurses do an excellent job interpreting these numbers and calling us, and pretty much they already have a plan in mind when they call me, which is great. So I don't have to do it. And then this is just our team in the news. Here's Dr. Langdon and Lindsay having an in-depth conversation, Micah and Dr. Stone and Nestor and Batter. I don't know what they're talking about. I will take any questions.
Hi, everyone. Good morning. Thanks for having me. I'm Karen Trujillo. I am one of the dedicated thoracic surgeons here at Methodist. I came in 2022, and really it's been a great journey for me, starting with having my bestie as a partner, and then Dr. Batter and all the other people on the team. So here we go. I like to do things a lot more informally. So if there are any questions at any point in time, just say something, or if you have questions about what I'm talking about, don't be shy. I am a consultant. I don't know really if can be considered a consultant for Intuitive. They begged me to please do one proctoring for robot lobectomy in Lincoln because their person had bowed out at the last minute. And so I said, sure. That was the only one time that I did it. So maybe pseudo consultant, whatever we want to call it. So what I'm going to be talking about today is lung cancer, and really how so many facets of it have changed, from the diagnosis to the staging to the treatment to the screening. I'm not going to talk so much about the treatment and prevention, but certainly we can talk about it at some other point in time. So brief history. In the early 1900s, lung cancer was pretty rare. The first successful pneumonectomy was in 1933 for lung cancer. And if anybody's seen The Crown, I don't know if you remember King George VI, he has a left pneumonectomy that was done in Buckingham Palace because he smoked like a fiend and he had lung cancer. One of the problems I think that is very well exemplified by that is that we didn't have very good screening tools or diagnostic tools or staging tools or anything, because the poor man already had cancer on the right side. He continued to have hemoptysis postoperatively and then succumbed to his disease. In 1939, Oshner and DeBakey, they published 79 cases of patients who underwent pneumonectomy, and that really was sort of the standard of care. If you had a lung cancer nodule in one lobe, the whole thing came out. And so that has really changed over time too. In the 1950s, Graham and Winder published a case control study in JAMA that linked lung cancer to smoking as a cause. And ironically, Dr. Graham dies of lung cancer in 1957. So clinical presentation, really when people present, how do they present with their clinical symptoms? Well, they might have cough, shortness of breath, hemoptysis, recurrent pneumonias, pain, and really what it is, it's pleuritic chest pain. So they'll complain of referred pain to their scapula, or sort of just generalized pleuritic pain. And a lot of times, if you're a never smoker, for example, and you go to your primary care physician or person and say, like, I'm having the shoulder pain, the first automatic thing that does not pop into your mind is lung cancer, which is why in the past, when you make a diagnosis based on symptoms, the diagnosis, the stage is usually later. And so that is sort of a missed window of opportunity, right? But now we have, especially in smokers or former smokers, we have the low dose CT screening CAT scans. And so that has made a tremendous impact on the stage of which we have been diagnosing these cancers, which then translates into, all right, well, instead of doing pneumonectomies, is there anything else we can offer people? Oh, well, maybe we can do lobectomies. Okay, is there anything else that we can offer? And down to this present day where we're offering sublobar resections. And I'll talk about that and show pictures, because for me, you can talk to me until you're blue in the face and explain what you're doing, but until I see a picture of it, I don't really get it. So I like pictures. All right. The diagnosis before was done on physical exam, chest x-ray, sputum, bronchoscopy, and then exploratory thoracotomy, which is horrific in my mind. These days, we're a lot more sophisticated. We have navigational bronchoscopies, and we can, our pulmonary colleagues, you know, huge kudos to them, because they are so good at getting these very distal, small pulmonary nodules and getting us a diagnosis before we go to the OR. That it's been incredible. We can, when they can't get to those nodules, we have our IR colleagues who can usually get a biopsy of the nodules transthoracically. We have endobronchial ultrasound to biopsy and stage the mediastinal nodes and the hilar nodes before we go into surgery. We could ask, we don't typically do an EUS, which is just upper endoscopy. But if there are lymph nodes that are by the esophagus, we'll ask our GI colleagues to do that for us. And we can also get liquid biopsies. So there are a lot of ways to get a diagnosis. For staging, before it was mediastinoscopy, a mediastinotomy, which is just an incision on your chest. It's really an anterior thoracotomy to get to the lymph nodes here on the left side, and exploratory thoracotomies. But now we have PET scans, brain MRIs, EBUSs, EUS, and thoracoscopy for still not really sure. For surgery, I think in the past, there was a high morbidity and a high mortality, I think, and that was due to a number of issues. Number one, it was a much larger incision. If anyone has ever seen any of the old school incisions, I call them shark bites, because you make an incision from way back here and you come across the chest and you cut through all the muscle and then you take out a rib. And that's really nice exposure for the surgeon, but it is a terrible postoperative recovery for the patient. And so I think that we have much better modalities to treat pain in our postoperative patients. And so that's one aspect of, I think, you know, for us to talk about today. Before, there was no standardization for lobectomy. And so there was a greater proportion of pneumonectomies. We know that pneumonectomies, especially on the right side, there's a much higher risk of having a bronchopleural fistula, and that is a dreaded complication. And for all of you in the OR, we know I have one patient I've been trying to deal with his bronchopleural fistula for almost 6 months now, 5 months. He's going to get a surgical repair now, because he's finally at the point where he wants to, you know, keep progressing and healing, and doesn't want to keep coming for like these minimally invasive options. So now really general thoracic surgery is a subspecialty. You know, I knew that I didn't want to ever do cardiac. I was almost tempted to go to the dark side, as I call it. But, you know, in the end, for me, my great passion, what I really fell in love with when I was a general surgery resident was thoracic surgery. I found it to be elegant, very nice. You know, you use the VATS, which is a thoracoscopy, a minimally invasive procedure. And I just really love that part of it. But maybe if I had, you know, seen cardiac surgery more as a resident, I would have bought into it. But I was like, oh, there's a lot of bleeding here. There's just no, thank you. No, thank you. It's so to each his own. It's all good. We're good. Now there's a lot more minimally invasive surgical approaches, and I'll talk about the different kinds. We have a refined patient selection. So we know that we can get PFTs, and based on our preoperative PFTs, trying to determine what the patient's postoperative functional status is going to be, and tell them, yes, you're a surgical candidate, or no, you're not. When people are borderline, we'll get perfusion studies to see if how much each lobe contributes to the overall ventilation, because that can also help you determine, you know, squidge somebody through. All right. And if that fails, also you can get a VO2 max and see, okay, is this person going to be a yay or a nay? I make all my patients quit smoking for 4 weeks before surgery. I'm one of the few surgeons who does that, but it's because I passionately believe that if you are smoking up until the day of surgery, there's literature to support that you will have a higher incidence of postoperative pneumonias, heart attacks, and strokes. And then your long-term outcome is not as good as those patients who quit smoking. And what I have found is that when you help people and give them nicotine replacement medications like Wellbutrin or Chantix, they are more likely to quit. And once they've quit in the preoperative area and then they get through the surgery, they usually don't smoke again. And so I think it's really a missed opportunity. I have gotten a lot of pushback from other surgeons who are like, their surgery, their cancer is going to progress. And really, there's one paper that I've been able to find in the literature that suggests that if you wait more than 8 weeks, there can be progression. But to me, it's super important because I've seen patients who have to go on ECMO after a lobectomy because they just go into acute respiratory failure. And then that then begets another issue of problems. Like this one lady perforated her bowel and she lived, but she wasn't my patient, by the way. But yeah, I was just like, why even, if plastic surgeons and orthopedic surgeons can make smokers quit because the post-operative complications are too high, why can't I make people quit? So that's my own thing. You either take it or you leave it. Anatomic segments. So this is just, instead of doing a lobectomy, now we're offering patients anatomic segmentectomies based on the size of the lesions. If they're 2 centimeters or smaller, patients, if they're in a good anatomic location, they will get an anatomic segment. We have better post-operative pain control and better post-op care. And so the post-operative pain control, for me, I did several years ago, I just was not happy with how people were doing with epidurals. They would become hypotensive, get a ton of volume on the floor, and then go into AFib. And then it would wiggle out, and since it was the weekend, the anesthesiologist was busy covering all these other services and wouldn't come and replace it, so the patient was in pain. And then they would get oxycodone, and then they can't poop or get really disoriented, and you keep circling down this drain. And so I did a deeper dive, and what I found was that if I did early recovery after surgery pain medications like Toradol, Tylenol, and gabapentin, but if I also did an intercostal nerve block in the operating room, the combination of those two is really remarkable, and people just do great. You see them in the post-operative bay, and they don't have pain. So it's a very nice modality. Lung cancer screening. So in the past, it used to be chest X-rays, done with chest X-rays, and we all know that those are not very good ways of determining anything because by the time you see it, it's advanced. Sputum cytology, which is not really a very effective screening tool because it doesn't reduce your mortality. Chest X-rays, they're terrible. We're doing the low dose CT scans for lung cancer, and especially people who have a history of smoking, people who are at higher risk, right? So anybody with a 30-pack year history of smoking, anybody who's quit within the past 15 years, the only caveat to this is that, we're seeing a lot of lung cancers in never smoking women. And we don't understand why. Some of it might be due to radon gas. Here in Nebraska, there's radon, and in the East Coast, there's radon. But we don't really have a good explanation for otherwise. And so, sometimes you'll get a history that maybe they lived in a house with parents who were smokers. Maybe their employment, they worked in bars. But we don't really have a good explanation. So anyway, the U.S. Preventive Task Force made these recommendations for low dose CT screening for lung cancer, and it is covered by insurance. So there's no reason why patients shouldn't be getting it. And even though these recommendations were made, I think I was a fellow, so 2008, 2010, there's still, I don't know that the word has gotten out there because there are a lot of people who don't get CAT scans to screen for lung cancer. So I think that we could certainly be doing a better job of educating the public and our peers and our colleagues and just say, hey, listen, if the patient has this certain history of smoking or was a former smoker and quit within 15 years, they need, just like you get your pap smear and your mammograms and all your colonoscopies, this needs to be done as well. So it's pretty simple, and it works. It will catch lung cancers at a very early stage. So this diagram sort of shows the stage of diagnosis in patients without screening. So you can see 15% of patients are stage 1 at diagnosis without the CAT scans, but that bumps up to 50% when you get CAT scans. And then stage 4 without screening, most of them are stage 4. Whereas now, with screening and you start doing through the workup, you'll find that 22% of your patients have advanced disease. Now, I like to tell patients that now is a good time to be alive because with chemotherapy and with immunotherapy, treatment has become a game changer. I recently operated on a 53-year-old woman, heavy smoker, I made her quit, who presented with 8 brain mets. And with lymph nodes all up and down her neck, supraclavicular nodes were positive, and bilaterally in her chest and a right upper lobe mass. And she had what appeared to be a complete response. And we talked about her tumor board, and they were like, well, would you resect her? And I was like, I can't really think of a reason why I would not. So we did the resection, the right upper lobe came out, all the nodes came out, they had no tumor in them. And we know that that patient's going to have the best long-term survival. And so it really, these medications, these interventions, these immunotherapies have been and are going to continue to be game changers. So more to come. The literature shows that there's a 20% reduction in lung cancer mortality with low dose screening CAT scans. So it works. It works. Okay. Chest X-ray is up here. And this is your death from lung cancer in years since randomization. This is from a study. And it shows that you have a 20% reduction in your mortality. So it is a good screening tool. All right. So from the screening that allows us to find smaller tumors or find tumors at an earlier stage, then we can also talk a little bit about the rise of minimally invasive thoracic surgery. So when I was a resident, we did open procedures, thoracotomies, and we did VATS. VATS just stands for video assisted thoracoscopy, 3 to 4 small incisions on the side camera, and you go in and you do your resection. And over time, you can see here that this is from the Annals of Thoracic Surgery, that as we have progressed, and this is dated back to 2010, really, there's a lot more people doing thoracoscopy. That has also increased, especially after the introduction of Da Vinci robot lobectomies. That has been a game changer, and we can talk about that a little bit. So video assisted thoracoscopy, what I just said, 3 to 4 incisions on your side, small. You are at the bedside, you're running the camera, retracting and dissecting. Robot assisted, and I'll show you the setup for both of these. Robot assisted thoracoscopy is a little bit different. You have a huge robot. You are at the bedside to put in the 5 ports for the robot. There are 4 ports for the robot arms and then an assistant port. And then you dock the robot, you put the instruments in, and then you scrub out and you sit in the corner in a little console and you do the surgery from there. There is a lot of controversy about which is better. And there will be people who will fight you to the death and tell you that the robot is better. And there will be people who will fight you to the death and tell you that VATS is better. They are pros and cons to both techniques. There's, I think, a very steep learning curve with VATS because you use a 30-degree scope, and that can be a very difficult thing to sort of appreciate in the OR. For me, the transition from VATS to robot was extremely hard because you also get a haptic feedback when you're putting instruments by the patient, and you can feel things. You're like, oh no, that's the airway, that's this, that's that. You lose all of that with the robot. And so it's a very different approach and feel even. And for me, it's a very steep learning curve. Now, saying that, I think for some surgeons who go from open procedures to robot, the transition is much smoother and they love it. And so I think that the robot elevates people and their surgical techniques. And I think that that is a good thing for the patient overall, period, end of sentence. I don't think that one is better than the other. I think that they both have their place in thoracic surgery. I think VATS now are really great for decortications. Then that's when you have a big empyema infection in the chest and the lung is all squished and compressed. And I like being able to use instruments that I can just put in there directly and scrape this sort of rind off of the lung. I don't think that we have that instrument for the robot. And, so for me, I'll sort of like try and tailor the approach to whatever process is happening. When you look at the perioperative complications and the length of stay, they're pretty much the same. There is a much higher cost associated with the robot because the hospitals usually have to buy the robot, and I think that they're $2 million a pop now. So it's very expensive. And as with all technology, they keep coming up with updates rather quickly. And so you have to keep buying stuff. And so it's like your phone, right? When you start off with your little iPhone 4 or whatever, it was like this little miniature thing. And you're like, oh, that's really cute. And now you have like an enormous or, much more fancy. It's really a fancy computer for your pocket. So anywho, those are the 2 minimally invasive approaches. I'm sure that as time goes on, there will be new robots coming out and then more pushes to do surgery that way. There is one surgeon who does not one surgeon. There's now talk of single port robotic lobectomies. And I know that that's going to be technically extremely difficult because it's just the nature of the beast. And, there are pros and cons to that. And I can talk to you in the corner if you want to about that. I have specific thoughts about that. Anyway, advantages of minimally invasive techniques. Number one is decreased pain. You don't have to transfuse as much, shorter hospital stay, better tolerated by the elderly, better tolerated by people with minimal lung function. You get earlier returns to normal activities. You're more likely to be discharged home rather than to rehab, and you are less likely to delay adjuvant chemotherapy. And out of all of these, I think that, decreased pain is a big one, because I always tell my patients, I'm like, look, the pathology is going to be what it's going to be. We don't care about that right now. The most important thing is that you have good pain control, because if you don't have good pain control, you will not cough, you will not walk, you will not do anything. You will not eat good food, and you're going to sit like a bump on a log, and you're going to get a pneumonia, and you're going to come back, and I'm going to have to reoperate on you. So just cut this off at the pass. You need to have good pain control. And on a scale of 1 to 10, 10 being the worst, I need you at a 3 or 4. And so I really try and get people to buy in. And even that way, I still have people coming to me post-op clinic 2 weeks later, like, I have so much pain. I'm like, well, what are you taking? Oh no, I wean myself off the medications. I'm like, God dang it. All right, let's start this over. All right, so VATS, this is just a schematic showing you the patient in the lateral decubitus position. And so this is where your incisions go. You usually want to triangulate. This is the back, the front, the arm. You put an anterior port, here is the inferior port, and a posterior port, and that helps you retract and put instruments. And you can always make this incision a little bit bigger if you want to feel something, or when you take the specimen out. This is a robot-assisted thoracoscopy. And the only reason I put myself here is because I got really, really annoyed. I was looking for pictures of surgeons doing robotic surgery, and they were all men. So I was like, oh yeah, I don't think so. It is National Women's Physicians Day, so I found a picture of me, and I just stuck it in there. Here is the setup of the room. So you have to have a pretty large room. This is the robot. Here's the arms. Here are the 4 docking, or the arms, so to speak. Here's the patient. And so these 4 arms, you have to put them a certain distance away from each other, so you're not fighting with your instruments. This is after everything has gone in, and I've already taken my gown off, and I'm sitting in the corner. And then you sit at the console to perform the operation. And then I scrub back in at the end to check the specimen and to put the intercostal nerve block, because for me, that's a very critical part of the surgery. All right, what I said just briefly before, talking about how minimally invasive techniques get you to chemotherapy if you need it faster. Okay, so this is comparing thoracotomies versus thoracoscopies. And so there's fewer delayed doses with the minimally invasive procedures. And that's super important. You don't want somebody who is elderly, borderline lung function to be in the hospital for weeks and weeks and weeks with post-op complications, because then you lose your window of opportunity to treat them with chemotherapy, plus minus immunotherapy. Usually, I think it's about a month later is when we can start therapy. So you really want to prevent any delay. Anatomic segment. So with the low dose CAT scans, the screening tools that we are using, we find nodules. We find a lot of nodules. 95% of nodules, though, that we find even in smokers are benign. So not everything that is a nodule is a cancer. You have to follow patients. You have to look at and see what it looks like. If it's spiculated, if it's not, does it grow over time? There's a lot of criteria. But now, at least for diagnosed lung cancers, if the lesion is 2 centimeters or smaller, what you want to offer your patient, if you can, is an anatomic segment rather than a lobectomy. And the whole thinking behind that is that once you've had one lung cancer, you can have another one. And so you want to spare as much lung function as you can, so that if you ever need to operate on this person again, they will have the lung function in order to tolerate another resection. And also functionally, they'll do better, right? So these are pictures of this is the whole right lung. Does this little pointer show up here on the screen? Okay, so this is the right lung is shown from a profile. Okay, so this is the upper lobe here. This is the lower lobe, and then this is the middle lobe. And you can divide the middle lobe into 2 segments, but a middle lobe, I don't really consider it to be a real lobe. It really is when you're in utero, all of a sudden you develop this other fissure here. Because if you look here on the left side, see, this is the left upper lobe, This is the left lower lobe. If I just make a line here, then I make another middle lobe here. On the left side, you don't typically have a middle lobe. But it's the lingula. The equivalent is the lingula. And so when people get really upset about me taking out their middle lobe, I'm like, it's not really a middle lobe. It's really truly an anatomic segment. It's just that you don't have a middle lobe on the left side because you have the heart. And so that fissure never develops. Anyway, all right. You can see that the segments are based on the anatomy. So the bronchial and arterial and venous anatomy. So you can have here in the right upper lobe, you have an apical segment, posterior segment, anterior segment. Here in the right lower lobe, you can have, the superior segmental, and then you can do either basilar segments if the lesion is down in the basilar segments. There are people, and I've done these too, but you do segmentectomies because the lesion is between, segment 9 and 10. And so it's good to have a very good relationship with your radiologist so that you can try and figure out where the lesions are. We also have a program that the pulmonary guys use to make maps to biopsy small nodules, and you can use that to figure out which segment the tumor is in, and then talk to your patients about anatomic segment based on that. And also showing them pictures. I show all of my patients the CAT scans in clinic with me when I meet them as new patients, because I don't like being like Charlie Brown's teacher, like wah, 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 wah. I just like to, I will explain, like, these are the axial images. These are the sagittal images. This is where the tumor is. Okay. Do you see that? Does that make sense to you? Yeah. Okay. And then I'll talk to them about the nerve block and all those things. Cause I'll have the ribs right there and be like, and then I do a little nerve block right here. And when you wake up, hopefully you're not going to have a lot of pain, because otherwise I would be sad. This graphic sort of shows a little bit about the trends that have changed in terms of lobectomy using the VATS approach here and then the robot approach here. And over the years, the robot has really increased. Oh, I got 5 minutes left. So sorry. Okay, I'm almost done. This just shows the trend of how people really like the robot. The robot, like I said, it elevates surgeons. It's easier, I think, to pick up if you're going from an open approach to minimally invasive. This one sort of looks at the difference between performing sublobar resections and lobectomies using the RATS and the VATS approach. And so, again, more people are doing sublobar resections and using the robot to do them. This is our team really of the thoracic people. I just included the people who do the lung cancer stuff and the lung stuff. So it's typically the 3 of us. And then, I don't think this is not here. No. Oh, okay. Well, I sent an updated talk where the newer numbers are there. We have continued to increase our volume with a little bump this last year. And I think that that's because the CHI hired a new thoracic surgeon. And so she's taking back the volume that they should have been doing in the first place. We are doing more anatomic segments than we have in the past rather than lobectomies. And I think that that's good because it's better for the patient. And so I can send you guys the updated talk with the numbers for 2023 and 2024. And I think that's it. So questions?
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.